can start early. So we will, with the permission of the audience and with my colleagues here, I think we should go ahead with the first talk. The first talk shall be by Dr. Mallika Goyal. Mallika, you're here?
Mallika was here.
Mallika was here. So next is Dr. Nitin Verma. Dr. Verma.
Dr. Nitin Verma is here.
Yeah, sir, can you start?
You can start.
Yeah, that's good. So the AV people can...
As he gets prepared, can I roll call? Dr. Srinivas Joshi is here.
I have taken a call, sir. Srinivasan is not there. Mohit.
Kenneth Fong.
Kenneth Fong is coming after some time.
Okay.
I was
Mohit
told.
Dogra.
Mohit is also not here.
Ramesh Venkatesh.
Dr. Mallika, she had come to the hall, but she's not there right now.
No, Mallika will come.
No, we will anyhow give them the
Alok
chance.
is there as well.
Alok is here. Yes, Alok is here. Yes.
No problem. We will start.
Okay,
with
so the first speaker coming is Dr. Nitin Verma. All of us know that he is a very, very senior faculty, and he is always looking forward to us visiting his country, his adopted country. So Nitin, over to you for high-dose aflibercept in macular diseases, reducing the burden of intravitreal injections. You have 7 minutes for you, sir.
Thank you, Prashant, and thank you for letting me be part of your session. Well, happy to start off on how do we advance these slides from the... Yeah, it'll work now? Arrow, right. Yeah, that's fine.
Next we take this, the third is
Good. So one of the main reasons why we get suboptimal outcomes in the treatment of macular degeneration or diabetic macular edema is undertreatment. The number of causes for undertreatment could be the financial burden, could be the burden on the carer, burden on the patient, and so on. And there are a number of strategies to try and get the injections at the right time, and not only at the right time, but also making sure that the patient is happy to keep accepting the treatment. And one of the philosophies is to increase the molar concentration of the drug that's injected. Now, everything starts from modeling, and PK modeling supports the concept of extended injection intervals if you increase the molar concentration of aflibercept. So, in this case, if the aflibercept concentration is increased fourfold, you can actually get 3 weeks more that the drug continues to act. And that's also borne out in animal studies, the chronic retinal vascular leak in the rabbit, showing that the drug, an increased concentration of the drug acts for longer. So what I'm going to talk about is the aflibercept 8 milligram dose, which is bundled into 0.07 rather than 0.05 mils of injection. The initial results from the Candela study, which sort of compared 2 milligrams and 8 milligrams given in a similar pattern, which is every 8 weeks, showed that the higher concentration of the 8 milligram concentration produced much earlier and more sustained reduction in the central retinal thickness, and the proportion of eyes without fluid in the macula, which is the green, was much more than the 2 milligram dose. And consequently, the visual gains were also much better at week 44. So here's a summary of what happened. And the side effects of a drug that we already know were no more with the 8 milligram than with the 2 milligrams. So then we go on to our experience in AMD and then in DME. The AMD one is the Pulsar study, where they compared, when I say 2, I'm also one of the investigators, but 2 milligrams of aflibercept versus given every 8 weeks, 8 milligrams every 12 weeks, and 8 milligrams every 16 weeks. A 1-to-1-to-1 randomization, and what we see is that's the dosing schedule. And because part of the thing is on a PRN model, not on a treat and extend model that we are used to, here are the criteria for shortening the interval in the first year and second year, and of course extension in year 2. So there were over 1,000 patients in this study. The BCVA outcomes were equal for all 3 arms. That is the 2 milligrams, 8 milligrams, 12 weeks, and 8 milligrams, 16 weeks. The central subfield thickness was also exactly the same. So what it means is that if one gives the drug at longer intervals, a higher concentration, you can achieve the same thing as you can, but with lesser number of injections. As you can see, the blue indicating 8.2 injections as compared to 12.8 with the standard Eylea. So that's also signed here. And in fact, more than half the patients could actually have gone on to more than 20 weeks. So if you think of it in your mind, that means 2 injections or maybe a little over 2 injections a year. That is a very comfortable level of dosing. This swimmer plot shows the same thing. And there were no new adverse events in this study. So no new safety signals, and this is a summary of what I've just been through. Coming on to diabetic macular edema, which is another totally different beast. The Photon trial, again, 3 arms, aflibercept 2 milligrams every 8 weeks with 5 loading doses, every 12 weeks and 16 weeks, but with 3 loading doses, a bit like what we do in macular degeneration. So it's slightly different from our standard practice. Again, looking at the criteria to decrease the interval or increase the intervals. The patient disposition is about the same in all groups, although the randomization is 1:2:1. Patient characteristics are the same, and about a third of patients had previous treatment with laser and other anti-VEGFs in the past. The primary endpoint, which is the BCVA or change at week 48, was equal in all groups. And at week 48, which is close to a year, all 8 milligram groups, more than 93% of them had a dosing interval of more than 12 weeks, so an injection every 3 months. At 96 weeks, which is the end of the study, 2 years, this relationship was maintained. And in fact, 90% of patients had injections more than 12 weeks, so every 3 months again. 47% of them could have gone on even further. And that's the swim lane graph, which shows you that, the results of what I've just explained. The central retinal thickness, the thing to note here is the blue line. As you can see, that's the 16-week dosing. And you can see there's a lot of fluctuation in the fluid. But ultimately, it comes down to...
Time is over, and you need to wind up.
Thank you. And so with time, it all settles down. No new safety signals, and that is the outcome. So thank you, but it just shows that we can actually use higher concentration to get equivalent results in both diseases. Thank you. Whoa.
Thank you so much. It was wonderful. Just a question before you leave us. Do you have some guidelines, like which patient? Do you customize your treatment or you follow the protocols?
Well, I think as we're all moving on, we are doing more and more of treat and extend rather than following the standard formula, because no 2 eyes are the same. The response is not the same. In AMD and DME, again, based on many other factors, if you get good response early, you can already start your extension earlier. You don't have to do 5 doses or 3 doses. That's the way I follow
that's what is happening. The new drugs are coming in. We are just head-to-head studies. We do not have comparative trials. So we do have to customize depending on your patient requirements.
Yes.
Is that the right way?
Yes, and I think with AI and all that coming in, it makes it easier.
Thank you. That's the next thing, AI coming up. Now we go to the next speaker. We would like to stick to time, please. Huh?
Yeah.
The next
Mohit Dogra is here.
Srinivas Joshi is here.
Yeah, no.
Are you ready?
Shashank Rai Gupta. Late.
Srinivas?
Yeah, Dr. Srinivas Joshi.
Srinivas is here. So if you can go ahead.
Next.
I saw Mallika around. I don't know where is she gone. Anyway, Alok, you be ready for the next one. Can you just, whenever after 1 minute, you can, yeah. You have put it there? Okay, so be ready for the next talk. So Alok will be talking next.
Good morning, everyone. At the outset, I would like to thank AIOS and Piyush Bansal, our AIOS Scientific Committee member, for this wonderful opportunity. I'll be speaking about the current role of lasers. As we all know, it's a light amplification stimulated emission of radiation. I'll not go into the details of the physics of it, but definitely the three things is the console, the control panel, and the delivery system. So I would like to touch upon the practical uses now. The pan-retinal photocoagulation is what we do for, especially when there is a neovascularization of the disc or neovascularization elsewhere, especially in case of diabetic retinopathy. It reduces the retinal ischemia and hypoxia, thus decreases the expression of the VEGF. And the spot size can alter, it starts from 200 microns, and duration can be from 50 to 100 milliseconds. Grade 3 burn, that is the threshold pale white, which is what is the textbook pattern, and of course depending upon the age and the status of the lens. So here's the classification of the chororetinal burn intensity, and what we require in case of PRPs is the threshold burn, not the subvisible or the barely visible or the suprathreshold. The grade 3, this is the threshold burn, is what is optimally useful for PRP. This pattern scanning laser, I think the multi-spot has made our lives very easy, and semi-automated lasering device that allows pattern of 4 to 64 burns to applied within less than 1 second using a scanning laser with shorter pulse duration. Relatively painless, shorter exposure, well tolerated, more number of spots in single sittings. You need not ask the patient to come and again for multiple sittings. The Pascal photocoagulator is safe and it's rapidly effective as published in various studies, and has short exposure time, short learning curve also, so it's definitely useful and has less adverse effects. So when we talk about the PRP, the complication of the PRP is also very important to be noted. The macular edema can increase, vitritis can happen, choroidal effusion with the heavy burns. It might sometimes cause even a tractional RD also in cases. So very important point to be put forward during the patient counseling. Now the focal laser and the grid laser. Focal laser is still in use. We use it for non-foveal edemas, direct laser to the microaneurysms, which is more than 500 micron to the fovea. The parameters can be the spot size can vary from 50 to 100 microns, duration of 50 to 100 milliseconds, and the power is titrated to tighten the microaneurysm. Grid laser not used very frequently nowadays, but still good to know. It's basically used in the area of diffuse leakage and capillary non-perfusion areas on the FFA. So laser basically it removes the unhealthy RPE cells, which are then replaced by more viable RPE cells. It stimulates the existing RPE cells to absorb more fluid, and definitely it increases the integrity of the inner blood retinal barrier, and definitely when we try to photocoagulate, we want to close the microaneurysms. So there are different types of lasers. Here is the frequency doubled ND YAG laser, argon green laser. And the targeted laser photocoagulation is also sometimes used in case of recalcitrant diabetic macular edema, where most of these are not working. Then few of the authors or few of the surgeons prefer to use the targeted laser. Is applied to the non-perfusion areas with the hypothesis that the VEGF level on the central comes down with these kind, and reduction of the ischemia and cytokine release, reduced need for anti-VEGF injection. Now in case of retinal vein occlusions, definitely we use it for macular edema, which are non-responsive cases. Large segment of capillary non-perfusion, that is more than 10 disc diameters, and of course for the neovascularization. We don't prefer it using it in cases of macular ischemia. The spot size in case of focal laser for the macular edema, again, it's 50 to 200 micron, duration is 50 to 100 milliseconds. What we do in case of these vein occlusions are mainly the sectoral laser with a spot size of 200 to 500 micron and area beyond 2 disc diameter from the center of the macula or the site of the blockage up to the periphery. So central serous retinopathy is again one thing which we should not forget doing the lasers here. Of course, PDT is now the difficulty there, but still in case of non-foveal burns, focal laser photocoagulation still has a role in case of non-resolving or recurrent CSCR, well-defined leakage on FFA, which is at least 500 microns away from the center of the fovea, and non-foveal leakage on FFA. So the most important we need to know for the subfoveal leakages are the subfoveal laser, that is a fovea-friendly laser, which is called as the MPLT. So here you can see just an animation about the continuous waveform, continuous wave output. What happens to the temperature bar? It keeps on increasing. As you see, there's more collateral damage. Heat dissipation is more to the surrounding. But in cases of the short pulse laser, that is the micro pulse emission, these are the short bursts of pulses of the laser energy which is delivered. And you can see this animation. The temperature bar goes up and comes down. So the cooling period is pretty much better here. And the collateral damage is also very much less with this micropulse technology. You can use it in in-plot or smokestack pattern, especially when it is in the foveal area. So another important thing about the lasers we need to know is retinal lesions predisposing to the detachments or the tears. And indications, high myopia, symptomatic lattices or even lattice with the holes, extensive lesions, SRF, that is cuff around the breaks or around the lesions, and RD in the other eye, and having a strong family history of retinal detachment, and sometimes before refractive surgery also, although we don't do it very regularly now, but only in cases of holes or having a high-risk cases, definitely we do it even before the refractive surgery also. So the parameters is 2 to 3 rows of the burns, spot size can vary from 200 to 500 micron, cover the entire perimeter of the break or the cuff until the aura, which is very, very important when we're doing it. The last thing I want to touch upon is the navigational lasers, that is the 532 nm pattern eye tracking laser integrates.
1 minute to conclude.
Yes, sir. So this is the video, just I wanted to show it. It's a pattern scan laser, navigated laser. In India, we can call it something like a rangoli. You know, preset pattern is fixed. The angiographic pictures come on the screen. You just have to paint it wherever you want it, wherever there's the microaneurysm, just put it. It has a very good eye tracking system. I have used it during my fellowship in 2012 to 2014. It really works very well. And even not only just for the focal laser, but also for the PRP also, it is pretty much useful because you just have to paint those patterns and then it does most of the work very easily. So and this is how I was trying to show it. You can merge that for microaneurysm, which is very close to the fovea, and definitely it has a very good tracking system. So what's new in Nevilas is the non-contact PRP. You don't have to use the contact lens nowadays for these lasers. Even with a non-contact system also, it can be done easily. So I'd like to acknowledge my colleagues, Dr. Rishikesh and Giriraj, and thank you very much for the patient listening. Thank you.
Thank you. May I request Dr. Chandran Abraham to please come and take his chair here, sir. Please do come. He's the father of lasers in India, and his experience is unparalleled. Over to you, Farhan. Thank you, sir.
Excellent
Thank you,
presentations. What is the difference in Pascal and continuous? Which you will prefer?
Sir?
Pascal laser as compared to continuous laser, which you will use?
You mean single spot versus the multi-spot? Multi-spot is more preferred, sir, more faster, less bone breaking for the retinal surgeons. And of course, even more convenient for the patients also. We don't have to call them again and again repeatedly, multiple sittings. Increases the ergonomic cost of the patients also, which decreases. And studies have shown that it is equally effective and safe.
Which are the definite indication of focal laser these days in diabetes?
We use it more commonly in non-foveal lasers where there's a large cystoid spaces in the non-foveal area. Of course, for the foveal area, now the anti-VEGFs, the longer duration of anti-VEGFs are taking care. But for the non-foveal areas where the vision is dropping down, not a good baseline, then it's better to laser those areas.
Okay, thank you.
Thank you, sir.
Thank you so much, Srinivas. I know now no more back-breaking, which our days with Shankar Netralaya. Over to Alok. Alok is our next speaker.
Yeah, good morning. So I'll be taking you through few of the cases. And every now and then we at Retina specialists, we get patients referred to us from our NTA segments colleagues saying that there is no improvement or in fact diminution of vision after cataract surgery. So the first case is a 65-year-old male who presented post-cataract surgery with loss of vision, and the history was of PCR and anterior vitrectomy, and you can see that there is an evident central retinal artery occlusion. And the FFA, although was normal, sometimes it is because of reperfusion, but OCT shows inner retinal hyperreflective, very suggestive of CRAO. Second case, again a 65-year-old, 60 years female, again had a PCR and anterior vitrectomy, and first post-op day, the vision was PLPR, and you see a very similar kind of FFA and OCT on the first post-op day. So CRA after cataract surgery is a known complication, although rare, and there have been several mechanisms which have been said, including vasospasm due to the periburbal injections of the anesthetic agents, adrenaline in the which we use, or because of the compression, mechanical compression it can cause, or raised IOP fluctuation during the surgery. The drug toxicity itself, sometimes we use some intracranial antibiotics. But what we noted in this series, the two cases that I've shown, was from a cluster of CRO that occurred within a month's time, 14 cases within a month's time, and we could find only one answer to it, and that was probably a residual ETO which was there in the probes. So, of course, systemic risk factors have to be kept in mind. This is the third case, which is a 60-year-old female who presented an hypertensive female. She had a post-op DM detachment, which was repaired by reposed by our cornea colleague. And on the first post-op after repair, there was a drastic fall in vision. And this is the fundus picture. You can see the tongue-shaped whitening of the retina in the peripapillary and foveal area and in the mid-periphery. Now this patient, if you see the OCT, you have hyperreflectivity of the outer layers. And this is suggestive of a posterior ciliary artery occlusion. And these patients can have occlusion if there is an acute rise of IOP, which could be due to pupillary block when you're using gas in these cases, and this reduces the blood flow in the posterior ciliary artery, and especially in a compromised eye. So the fourth case is a 71-year-old male who presented with diminution of vision after phacoemulsification, and the post-op day 1 vision 1/60. And you can see that there is disc edema, the margins are blurred, and there was RAPD. And this is the OCT and the picture of the same patient, and you can see on FFA there is differential filling and late staining of the disc. This is at 1 week, the vision improved spontaneously, and you can see that there is altitudinal field defect. So this was a case of NAIN which had occurred after cataract surgery. So risk of NAIN after cataract surgery is actually about 5 times higher than otherwise, and the risk is maximum during the first 6 months after surgery, and higher age group has been associated with this risk. The mechanism is again hypothesized as raised IOP or vasospasm due to regional anesthesia, or even post-op inflammation, which has been said. My last two cases are a 65-year-old male underwent uneventful small incision cataract surgery. Unaided vision at the time of discharge documented was 618, and the patient came back after 1 month with this fundus picture and a vision dropped to 6/36. And you can see that there is an occlusion of the superior branch retinal artery. And what you also see in the periphery, these RP alteration with hemorrhages. Now, when we did FFA, you see that there is a lot of window defect or transmission hyperfluorescence in the periphery with the occlusion of the supratemporal artery. And you can see the hyperreflectivity on the OCT, inner layer hyperreflectivity on the OCT itself also. And again, another case with 19-year-old male who had sudden diminution of vision in the right eye, and he had history of trauma with a nail piece where there was a corneal tear repair was done. And during the tear repair, there was a subconjunctival injection of gentamicin that was given. And this was the fundus picture post when the patient was referred to us. And you can see that there is a large area of retinal whitening with occlusion of vessel, and on OCT also you see hyperreflectivity. So gentamicin toxicity, we all know, it causes macular ischemia if it is inadvertently injected into the eye. But prophylactic subconjunctival injection of aminoglycosides can also lead to retinal toxicity, especially if it is injected near an area of weakness or where the sclera is thin. So these were my cases, and some of these cases we had over a period of time. Yeah, thank you.
You can continue.
So that's it. Yeah, I finished it. Thank you.
For being on time. Yeah, Dr. Manish.
Yeah, I think that was a
Bye.
great collection of cases. Unfortunately, nothing much we can do about them. It's a scary cluster of CRAO. Never seen that in cataract cases. But I guess very important take-home points is don't overinflate the anterior chamber. Make sure that the pressure doesn't go high because cataract surgeons tend to make eye very firm. Intraocular injection, intracameral injection of vancomycin is known to cause HORV, so that's another important point. And I think it's also important for diabetic patients. We need to inform these patients about, the surgeons have to be informed about chances of DME. They need to prompt their patients that the DME might worsen. That's another vascular problem that might happen. Thank you.
Okay, Mallika, you're the next person to come. Can I request the organizers to just arrange for some more chairs? You know, we're feeling it's overfilling.
Front,
Some
you can
vacant chairs are there. Please find
Some-
it
You can
second
come
also
front.
that other people can come inside.
Yeah, and then we can put some extra chairs if it's possible.
There are vacant seats, come inside. 2 seats are here also.
Yeah, you can take
Come,
these
come.
chairs also, no issues. Yeah, over to Mallika.
2 इधर है, एक इधर है. Okay.
Okay. So good morning, everyone. I'll be speaking about my experience with aflibercept, which really in many patients allows very long treatment intervals and has been a big relief from the previously available agents. I'll be speaking about my experience in AMD and PCV. So while this is a talk sponsored by Bayer, this, patient is always first for us. Nothing else is important. We started using aflibercept in eyes that were non-responding to ranibizumab, and then we realized its strength, speed, and longevity of response. And strength and speed lead to better final visual outcome by preventing foveal damage from chronicity of fluid. Longevity reduces the treatment burden by reducing not only the costs but the risks of endophthalmitis and other complications of each injection. So reduced treatment burden, and most importantly, it continues to enjoy the highest safety of all available anti-VEGF agents with regard to inflammation, occlusive retinal vasculitis, etc. So we also then started finding that several of these patients were able to actually go off therapy totally for very long periods of time and even indefinitely. Like we used to see after we did PDT for non-responding cases, which PDT is not available now. And for these reasons, it rapidly became the drug of first choice for us. We do know that it targets 2 molecules, the VEGF and placental growth factor, which gives it the strength of efficacy as well as the longevity. We know from Altair and ARIES that 40% of the patients can be extended to Q16 and an additional 20% beyond Q12. And based on this, there was a meeting in UK which allowed practical implementation of a Q4 to Q16 treat and extend pathway with aflibercept. And there's a recent study from Wilmer Eye Institute which found that 43% of AMD patients treated with aflibercept could safely stop treatment after 1 year, which is 3 times more likely to happen if they were being treated by bevacizumab. So we'll just see some of our patients to illustrate these points. This is an elderly gentleman with PCV. There is a polyp on ICG angiography at presentation. Initially, he responded to ranibizumab, but then did not come and came back with a reactivation and bleed. At this point, ranibizumab was ineffective even for fluid resolution. Aflibercept, there was resolution of fluid as well as the RP detachment and blood. After 3 monthly injections, the polyp had regressed. And subsequently, there was no activity. We continued to extend the treatment interval up to 6 months, Q24, and then stopped treating him. But he was under observation with no activity and 6/6 vision. So aflibercept can cause polyp regression. Treatment interval can be greater than 624, and we can stop treatment. Another lady with the PCV, polyp, 5 injections, the RPD settled down with 5 injections of aflibercept, and subsequently we were able to extend out the treatment. The polyp has regressed completely, and that area has not become active again. This is another lady with bilateral AMD. So I'll be speaking only about one eye. The course of the 2 eyes remains roughly similar. So this right eye, we treated her with aflibercept because she's already been treated outside with poor response. After that injection, she did not have any reactivation subsequently, the first injection. We still treated her at 4 months, then again after 6 months interval, just to avoid a reactivation. But we never had any activity till just last month, which is almost a year after the last injection. And patient is still asymptomatic 6/6. She just came for the routine follow-up. So we treated her. And you see the Octa shows that in this time, the CNVM has completely regressed. So treatment intervals can be greater than Q24 with aflibercept, and you see here it was 11 months. Each eye was treated with only 5 injections in over 2.5 years, with retention of excellent visual acuity, 6/6 in the right eye. Another one-eyed lady, because other eye lost to AMD, we started with aflibercept because the other eye had been lost already. And you see there was some reactivation at 2 months, so treated again. But thereafter, this is almost 2 years back, 2.5 years back. Thereafter, there has been no activity. We have treated her once in a while just to prevent problems. But the last injection is over 17 months and no activity, with retention of 6/6. Another lady, bilateral AMD, similar picture. Right eye treated, no activity after that. Vision immediately improves. Activity happened after 6 months of the second injection. So then we decided to treat her at 6 months, though there was no activity. And that was a year back. I saw her a few days before coming, and there is no activity at 1 year after the last injection. So we treated her with 4 injections in over 2 years, and the last interval is 12
Dr.
months.
Mallika, 1 minute to conclude.
Yeah, I'm just finishing. So another patient with a similar picture, a fellow eye of the same patient which did not respond 10 years back except to PDT, and then came back with reactivation, and this time PDT was not available. But with aflibercept, very few injections, once in 6 months. She has no activity now and a dead tree appearance on Octa, good vision. And this is to show that in peripheral PCV cases, which are also very common, the macula is not involved. Treatment intervals can be even larger because the margin of safety is larger. So to conclude, due to its strength, speed, and duration of action, this drug has drastically reduced the treatment burden in AMD and PCV and other indications. 30 to 40% of the patients can be extended beyond 6/16, with gradual weaning off of treatment in many after 1 to 2 years. And most importantly, it has the highest safety of all currently available agents. And we await the high-dose aflibercept, which will have the 100% safety with 85% possibility of extension to Q16. Thank you.
Thank you, ma'am, for the Thank you, ma'am, for the excellent presentation. Just one question. The PCV responds well to the aflibercept, but in case of recurrence of PCV, do you prefer to continue the same aflibercept or higher dose or a different anti-VEGF agent?
No, I would continue to use the same because it has very good effect. Once you give injection, most patients don't need for several months, 6 months, 12 months, 14 months. So I have no reason to shift. And of all the currently available agents, given the efficacy and safety, this is the best. Because the safety, even now, this remains the best, even with the newer agents that have come in.
Sure. So just other way around, what will be your criteria to shift from aflibercept to another agent or a higher dose of aflibercept?
Yeah. So the criteria will be where the patients are. There are patients who still need at 2.5 months intervals, let's say 2 months or even some 6 weeks. Those are the patients where we would like to try and extend the treatment interval if they are agreeable to the small risk of inflammation and retinal vasculitis. So those are the patient non-responders where you have to give very frequent injections.
Sure. Okay. Thank you very much.
Thank you.
There are some chairs are coming in, please. I'm sorry for this ordeal of our guests. We have the next speaker, Ramesh. He'll be talking to us. Over to Ramesh.
Yeah,
please, there are 1 or 2 chairs here, and they can be occupied.
So thank you so much. I'll be talking on therapeutic targets for anti-VEGF agents, molecular insights, and clinical translation. So we know that in the current market, we have a lot of molecules which are being developed, and these molecules have multiple targets, and therefore more anti-VEGFs are being produced right now, and therefore it creates more confusions in the clinical practice. So when you have an anti-VEGF agent, it requires 3 levels of assessments to be done. One is at the level of efficacy, whether that anti-VEGF molecule is efficacious or not. Second is the durability of the drug, and third is the safety aspect to that anti-VEGF molecule. Let's talk about the anti-VEGF efficacy itself. And we know that in most of the retinal and the choroidal vascular diseases, it is the increase in the VEGF and the placental-derived growth factor because of the secondary hypoxia, which causes the VEGF receptors or the VEGF isoforms, VEGF and the PIGF levels to go up, which causes the secondary inflammation, neovascularization, and vascular leakage and edema. So basically, aflibercept, it has a multiple target approach where it acts at the VEGF receptor 1 domain and the VEGF receptor 2 domain, therefore blocks the VEGF receptor, VEGF isoforms A, and the placental-derived growth factor, and therefore it is useful in reducing as a significant anti-VEGF level. In addition, it has got action against the VEGF B as well as the galectin-1 molecule as well, and therefore aflibercept has been considered as the standard of care outcomes through different multiple targeted approaches. Now, what's important to understand is, do you have any additional targets which needs to be considered beyond the VEGF receptor so as to increase your efficacy outcomes? And this is an important question which needs to be raised. And therefore, we have newer molecules coming up with smaller size, with high molar dosing, with the brolucizumab 6 milligram, molecules which have additional pathways of action where they are acting against the Ang2 levels with the faricimab and the nesvacumab, and then the surgical implantation of the ranibizumab molecule as well. So let's understand in detail what's the role of Ang2 in the vascular permeability and angiogenesis in neovascular AMD and DME and DR. And you would realize that it is the Ang1 which is a protective agent. It binds to the Tie2 receptors, and therefore it reduces or stabilizes the vessel wall and prevents the prevents the increase in the vascular permeability and therefore the leakage and the edema. Whereas the Ang2, which gets upregulated because of the increased VEGF receptors, it gets connected to the Tie2 molecule and therefore destabilizes the vessel wall and causes more leakage and therefore edema and angiogenesis. So this is a very important slide which tells you that it is the low VEGF levels which promotes the Ang1 get connected with the Tie2 receptors, and it is the high VEGF levels which is responsible for the upregulation of the Ang2 and therefore blocking of the Tie2 receptors, which is responsible for the pro-angiogenic and the and the inflammatory cytokine action. So faricimab, we know that it's a bispecific antibody which works against two molecules, that is the VEGF agent, which is the VEGF agent, which is a part of the ranibizumab arm, and the second is the Ang2 action as well. And it also has a modified FC fragment, which is very important because it reduces the risk of systemic exposure and reduces the inflammatory potential as well to any of these anti-VEGF agents. But does Ang2 inhibition contribute to better visual and anatomical outcomes? And this is where the clinical trials will actually help us in understanding. So this is a trial which was performed by Bayer and Regeneron, where they actually looked at the binding affinity of faricimab to the Tie2 receptors and nesvacumab to the Tie2 receptors, and they found that faricimab actually had a weaker binding for the Ang2 compared to nesvacumab. Now, when you look at the Ruby and the Onyx studies, which actually compared the role of nesvacumab in combination with aflibercept, and you would see that whether it is adding nesvacumab, which is an Ang2 receptor inhibitor, the visual acuity outcomes did not change much in comparison to the aflibercept monotherapy group alone. Even the Avenue study, which compares between the faricimab and ranibizumab in neovascular AMD, did not show a significant difference in the visual acuity gains over a period of 36 weeks in patients who were treated with faricimab with the 1.5 milligram dosing, 6 milligram dosing, or even a 6 milligram monthly dosing schedules. Now, the most important study, or the most commonly spoken about study, is the Tenaya and the Lucent study, which compares the faricimab against aflibercept 2 milligram. And this additional blocking of the Ang2 agent with the faricimab did not give a superior visual acuity or an anatomical benefit over aflibercept. And this is something which you can see that over a period of 112 weeks, the visual acuity gains were almost comparable with faricimab and aflibercept, both in the Tenaya and the Lucent studies. So the first clinical implication which I want to tell is that the low HF levels can be achieved by just suppressing VEGF, and you probably don't need an Ang2 blockade to be seen. Now let's look at the durability, and you know that there are three important things which increase the durability of the drug. One is increasing the molecular size, second is the binding affinity, and third is the molar dosing. And these graphs really clearly say that when you increase the molecular size, the binding affinity, and the molar concentration, and therefore the VEGF suppression time is increased in these cases, and therefore the durability of the drug increases. So you have the Pulsar 8 milligram study which spoke about the neovascular AMD, where it compares the 2 milligram every 8 weeks, the 8 milligram every 12 weeks versus the 8 milligram every 16 weeks. And you see the proportion of the patients who have got extended beyond the 12 weekly interval, which is around 62 to 65%. Even in the Photon study, you have a significant amount of patients, 91% of the patients who are able to achieve a 12 weekly treatment-free interval, and an 89% of patients having a Q16 treatment-free interval, which is much lesser with the brolucizumab group and even with the Alter study group. The TENAYA study, which also talks about the 16-week interval, is only about 45.7% to 44.9% in the TENAYA and the Lucent studies. And therefore, the second implication which I want to say is that the aflibercept definitely has got an increased durability in comparison to faricimab 6 milligram. Let's talk about the safety, and you know that the immunogenicity is related to the high monoclonal antibody levels, the high disease state, and the presence of pre-existing inflammation. And sometimes the modification in the FC fragment provides better protection against inflammation. Just to summarize, the VEGF is the main pathway in the management of retinal and choroidal vascular diseases. Ang2 promotes VEGF destabilization and increased leakage and angiogenesis. High VEGF upregulates the VEGF Ang2 levels. High binding, high molecular weight, and high molar drug concentration increases the durability. At the same time, it raises safety concerns, and safety of aflibercept in Photon and the Pulsar study is comparable to that of aflibercept 2 milligram. Thank you so much.
Thank you, Dr. Ramesh. I just want to ask, what is your first-hand experience between faricimab and aflibercept in functional and structural outcome?
So recently only we have started using faricimab. So we have only 2 patients who have got the 1-month follow-up visits, and we have seen a good improvement, which is almost as comparable what you get with aflibercept as well. Both the drying effect and the anatomical and the visual acuity gain is also quite comparable with aflibercept.
Right. Okay.
Thank you so much, Ramesh. We have the next speaker, Shashank Gupta. Are you ready? Yeah. Please. We have time because I think we are missing 1 or 2 speakers. Let's see. One speaker only, so we have a couple of minutes after this. Any idea about Bufenor? Is Bufenor around? No.
She's not there. Kenneth Feng is there. He is coming at 12.
Okay, Kenneth Feng is there. So, okay, we have one more speaker. Okay, over to you, sir.
First of all, I would like to thank the organizing committee for asking me to speak on this topic. I'll be speaking on refractive DMEs. Diabetes mellitus is going to be a big global epidemic, and DME is the most common cause of visual loss in diabetic eye. DME pathogenesis is extremely complex, as we all know, and it is very important to identify each contributing component to plan its prudent management. The introduction of anti-VEGFs led to a breakthrough management in DMEs, and differences between anti-VEGF drug has been explored by Protocol T, and they find that each drug was found to be improving vision as well as reducing the CRT. But despite the efficacy of anti-VEGF agents, at least 40 to 50% of DME eyes experience persistent DME after at least 6 monthly injections of anti-VEGF, and 32% of them have concomitant visual loss. So it's a big data. Persistent DME remains a challenge because it leads to permanent disruption of retinal architecture, causing photoreceptor loss. What is persistent DME? DRCI.NET defined it as eyes with CRT of greater than equal to 250 microns at 6 months of follow-up, despite receiving at least 4 of the potential 6 protocol-mandated anti-VEGFs during this period. So despite of receiving good number of injections in initial phase, 40 to 50% of the patient will be landing up in persistent DME, or what we call as refractive DMEs. So what all we need to do? From the very beginning, it seems like 4 of the 10 patients will be landing up in persistent DME, so we need to plan it well. So from the very beginning, we need to look into the systemic status of the patient. We need to go into the drug history of the patient, check for any surgical histories, ensure compliance at the very beginning of the management, do counseling of the individual patient as well as their families, and do routine baseline investigations. Biomarkers play a very important role in deciding the future outcomes of these patients. Ellipsoid joint disruption, disorganization of inner retinal layers in 1 mm foveal zone, and lower parafoveal vascular density in the superficial layer of OCT are poor biomarkers of final visual acuity gain and improvement in the CRTs. Some studies have suggested initial subfoveal choroidal thickness to be checked. Greater baseline choroidal thickness are more likely to respond to anti-VEGFs. As we all know, presence of SRF and hyperreflective spots denote inflammation, and certain studies have told that in these cases, steroids work better. Recently, aqueous humor cytokine levels have been used as biomarkers that could help anticipate response to anti-VEGF therapy, and elevated ICAM-1 and reduced VEGF levels at baseline were associated with favorable anatomical outcomes with anti-VEGFs in DME. So when you are landing up with so many patients in refractive DMEs, what is the treatment protocol? What are the options that we have? What all things that we can do? So we can do either anti-VEGF switch, we can switch to steroids, we can plan vitrectomy, or we can add lasers. So we'll go through them one by one. Anti-VEGF switch means that whatever anti-VEGF you are starting with, if your patient is not responding or has stopped responding to that anti-VEGF, you shift to the next one. What I routinely start with is ranibizumab, and when it doesn't work or it stops working, I shift to aflibercept because it has shown superior effects on vascular permeability and make it more suitable for high VEGF levels. If my aflibercept patients stop responding, then I shift to either Broly or faricimab of late. So these are the few patients which started with ranibizumab and landed up with refractory before shifting it to aflibercept, and few of them responded nicely, as you can see on the right side. Question is when to shift. DRCR says after 6 consecutive monthly injections. But that is not practically possible in our scenarios, and what in practice we do, or what the latest studies are telling us, is that after 3 consecutive monthly injections in treatment-naive cases, or 2 consecutive monthly injections in cases who stop responding to the injections. But ensure that patients don't drop out of the treatment, because we have seen that patients who drop out and do not take injection for 2 to 3 months, they generally land up in more refractive DMEs. When to shift to steroids and why to shift to steroids? Because as we all know, it is stronger anti-inflammatory, acts on various pathways. Again, the question is when? Not after 6. Again, the study says that persistent DME might benefit from a switch to dexamethasone implant early. That is, after 3 anti-VEGFs rather than 6. So these are my case, same case in the right eye and the left eye. Right eye we kept giving anti-VEGF and kept responding, but on the left eye it didn't respond well to anti-VEGFs, and then we treated with steroids and patient improved certainly. Going to lasers alone does not work well, as we all know. But of late, there is a lot of interest in micropulse lasers when you add it with anti-VEGFs. When lasers are added with, micropulse lasers are added with anti-VEGFs, many studies have proclaimed better anatomical as well as visual outcomes. But all these studies are having limitation as they are small sample size, retrospective and short follow-ups. Coming on to the surgery, It has a proven effect in tractional DME, but no consensus so far in non-tractional DMEs.
Shashank,
Positive say,
time is up, but
Sir,
you
1
can
minute
extend
I'll
one
take.
more
Yeah.
minute. Yes, we have a lot of time afterwards.
PPV leads to, it allows VEGF and pro-inflammatory cytokines to diffuse, but on a negative side, it reduces the half-life of intravitreal agents. So I skip this and come to this picture. So what we proclaim and what later studies are proclaiming, that rather than giving many anti-VEGFs and steroids and then landing up in this case and then think about surgery, same in this eye and the other eye, we should think about the surgery early in the course. So not after trying all anti-VEGFs, all steroids, all lasers, and then we come to surgeries. Rather than that, we should come to think about surgeries early in the course as we do anti-VEGF shift or steroid shift. After 1, 2, or 3 injections, the surgery will work then better and will give more structural as well as functional outcomes rather than doing it in this stage. So there are future perspectives. Many new molecules are coming, which may individually or in combination help us reduce this load from 40 to 50% to maybe 20 or 10. This is what all of us are working. Thank you so much, and I invite you all for 10 Delhi Retina Meet in Delhi. Thank you.
Thank you, Shashank. It's a nice presentation, but it's very complex. Your presentation itself shows that it is very complex problem, and there is no single answer for all the audience. I am telling, if some refractory diabetic macular edema comes, what is your first step? Shashank, where are you?
Sir,
What is the first step?
First step is definite.
Someone has taken multiple injections, has defined chronic macular edema. He came to your clinic now. What is the first step you are going to take?
Sir, if patient has already taken multi-anti-VEGFs and is not responding, first of all, you tell the patient that chances of you responding are very less. So I, rather than treating that patient at that stage, I would like to shift early. Rather than trying 6 anti-VEGFs, I try to do 1, 2, or 3 anti-VEGFs and then do a surgery. Because whenever I am doing surgeries with ILM peeling early in the course, I am getting good structural and functional results, and there is almost total disappearance of DME when done in time. And
Yeah.
you don't need repeated injections.
No, I would first rather go into the systems, whether this patient is having a deranged systems. Most of the time, believe me, people who have come with multiple injections, their systems are deranged very worse. So you need to stress upon that unless your body is under stable status, you are not going to respond. This part most of the people miss. What systems will you look in
So
if the patient is?
That is the basic understanding that we.
I understand,
Yeah.
but people stop.
We
doing
need
that.
to check the HbA1c levels. We need to check the steroid, this cholesterol level. We need to check the blood pressure. We need to check the nephropathy and anemia. So all these factors have to be looked into. If any of them are deranged, that has to be simultaneously worked upon and bring to an optimum level.
And cardiac, you should also look for sleep apnea, and microalbuminuria. Most of the people declare that their kidneys are all right, but they are deranged grossly on microalbuminuria. This need to be taken care. Means a chronic diabetic macular edema is an indirect indication that fluid retention is happening in the body, and you need to address that. Unless you are addressing that, injections do not help. Second, once you are committed for injections, it is a limited period. You need to stress on the patient that you need to get all right, otherwise I may have to repeat the injections one after the other. So there is nothing called very refractive this thing. This is mainly because the patient is insensitive for your treatment. He is also tuned to, okay, only injections is the treatment and nothing else. So we are hitting the wall in those cases. So diabetic macular edema, your approach should be holistic rather than a simple repeat injections or not.
Rightly said.
Post-vitrectomy macular edema, how to deal? Post-vitrectomy macular edema.
So the only option is dexamethasone for longevity sake. Otherwise, you can try repeated frequent anti-VEGFs.
Yeah, implants is the answer for those cases because the turnover rate for this thing is very faster, all the other injections. One thing which I say the surgical option, if you see the OCTs, there is hyaloid, though it is not traction, there is a thickened hyaloid is there.
Posterior hyaloid.
Yeah, generalized traction will be there.
But in
these
those
cases.
cases, it didn't start up with that. It landed up with that during the injections.
I know that, but once it happens, the traction is persistent,
Yes.
and reason for the this thing, you should address that and relieve that. That would be another option which you have. Thank you very much.
That was great. Do we have the next speaker? Dr. Kenneth Fong? He's another session. So Ashish, yes, Ashish, please come. Whichever is okay with you. We'll have some time for questions, discussion, because we just have one more speaker.
Yeah, we expect a lot of questions from the audience because everyone practices medical retina. These days, that is the most common specialty along with refractive surgery. I inquired a lot of youngsters. They said refractive surgery plus medical retina. So we expect a lot of questions from the audience. We have some time to address.
Gopal, hold on.
Please
you
be
don't
ready.
go because this is a very important session.
So good afternoon, ladies and gentlemen, and thank you for having me here. And I am asked to talk about whether biosimilars are there to rescue in the management of chorioretinal diseases. I have disclosures in last 12 months. I do have disclosure with various biosimilar companies overseas and here. I do not have disclosure, though, for any companies in this particular presentation. So we've been trying to understand biosimilars from various point of view, whether it's phase 3 trial design, whether it's real-world data, or whether what happens in terms of the switching. So, and what is the kind of immunogenicity that you can expect. So this is our contribution in the forms of various publications in last 4 to 5 years. And I would definitely like to acknowledge this wise group of collaborators across the globe who have been part of all these studies. So before I proceed further, I have a question for this particular wise audience, that how many of you are aware of biosimilar anti-VEGF? If I can have a raise of hands, please. Great. So I see approximately 60 to 80%. And next question is, how many of you are using that in your practice? So again, this comes to approximately 60 to 70%. So awareness is there approximately in 80% of the audience which is here, and users are approximately 60% that I see. So rescue means, what do we understand by rescue and why are we even talking about this? So if you really look at the entire structure and the availability of molecule that previous speakers have talked about, and Dr. Shashank, I liked your one slide that you said, I start with the ranibizumab. That's where we are. So the gap which was there for the rescue was between Avastin and Lucentis. So this was a big gap which was not being filled up. So we were starting with Avastin, and Shashank said, now I start with ranibizumab. Why? Because biosimilars are financially able to fill that gap now. Now, why that gap? There is a need behind it. If you really look at the entire population of India, we are not a great country in terms of statistics, but overall, whatever data we have, you require approximately 1 crore of patients anti-VEGF injections every month. Do we have that kind of affordability? We do not have. Whatever data that we have a lot of non-affordability. That's why there is a big dropout. This is not the question of our country alone. Means I work with Cimerelli and Biogen also. So what we have seen when I was in academy a couple of years before, when we were talking about biosimilars, in US people were not ready. That they said this would not work in the States because Avastin is something which we believe in, and Avastin is being fractionated in this country very well. So biosimilars might not have a great future in the United States. I was in Retina last year. I spoke to the same team. Now, you know what is the stats in United States now? Biosimilar ranibizumab has taken over the Lucentis usage in the United States. in terms of the percentage. So that's what it does. We have non-affordability on ground with patients, but you see the more robust systems, developed system, non-affordability comes in the system. So insurance is something, which will decide. And whether they have filled this gap or not, I will tell you by the survey. I lead an international group of biosimilar study, which is called InterBios Group, which we are trying to understand various parameters. So we had a survey that whether the rescue has happened in India or not. So what we asked that what proportion of your patient, I think this answer we have just received by this poll in this audience itself. So you see biosimilar users are approximately 75% of the proportion of various practices is with biosimilars. And where Lucentis stands, it has shrunk down to less than 25%. Prime reason for usage of biosimilars, it reduces cost to the patients. That's what the rescue was we were talking about. Do you think they have made a greater impact in terms of affordability? Yes. Do you want to use it in future? Yes. Rescue, as I said, this is something which has definitely come for rescue, and it has indeed filled the gap. This is a recent paper that we published. Means I wanted to highlight this because when I talk about biosimilars on any platform, after the talk, a lot of people come that, whether this molecule is better, this molecule is better. Somewhere the clarity is lacking because they are, people are listening about different molecules. So let me clarify here. Just look at this table of our 1 minute.
Please ignore that signal.
Yes.
You can continue as long as you can.
Yeah. Thank you for that.
No, we have time.
No, but still, I will maintain time. I do that. So, but I will take 3 seconds, which you interrupted me. Sorry for that. So, just to really summarize that who is the originator molecule and who is manufacturing it and who is marketing it. So we have the oldest molecule, Resumab, which is manufactured by Intas. It is being marketed by only Intas. So Intas has only one molecule. Then comes Ranizorel, which came after Resumab. It is manufactured by Reliance. It is being marketed by Cipla under the name of Vizumab. Renize, manufactured by Lupin, marketed by Sun as Osiva. And then Optimab, recently launched molecule, not come because of the initial trouble. So this is the rescue. I would quickly do that because 5-Avastin, I practice in Tamil Nadu. So sometimes government schemes, suddenly they do not approve. When they don't approve, then the next, your option is biosimilar. So these are some of the case examples there. Biosimilars could really rescue all these patients who were not financially well. So I firmly believe that many lives can become better, and they have become better. And if you believe in biosimilars, and if you have a cautious eye on them. Thank you so very much for your kind attention.
Thank you.
Thank you so much, Ashish. We always look forward to your talks. I just want to now, we are talking about India. I mean, we still believe that in US, 50% of the diabetics don't get access to these biosimilars.
It is, so US, we are talking.
Jocelyn Group study.
Yeah, so what happened is now, in last 2 years of data, if you see, US has 2 biosimilar ranibizumab molecules approved at this point. So Biogen molecule was approved only for neovascular AMD because DME dosing, which is approved in US, they did not test it. Okay. And that was the molecule which came first. Then next molecule came from Coherus, which is Cimerli, which is everywhere. If you look at Cimerli is available in United States, Europe, and UK with different names. So what happens, Cimerli, for the first time in the history of medicine and history of FDA, has received interchangeability approval without any additional testing. So suddenly, Cimerli got that approval, and now you see, within last 2 years, the amount of users have really gone up. I am doing a real-world data collection. I have 3,000 eyes to analyze for Cimerli now, and these are all across the globe. So, as you rightly said, the access part, That's what biosimilars they do. As of now, even in US, access is a trouble. But US comes to a bottom of the pyramid. Access problem is predominantly more in Europe, and Europe is the most mature nation as far as biosimilars are concerned. So this is the primary reason that biosimilars, they come in, they increase the access, whatever they have done. So you are right, because even US access was an issue.
Sure, that's great. And you mentioned about different companies marketing these Indian biosimilars. How do that make a difference between, adaptability? Like we ask the patient, should you go for this brand or this brand? Does it make a difference? Like Reliance creating or,
I mean, ideally speaking, this is the same molecule. This is the same molecule, so it doesn't make any difference. The only thing is, my worry means, which I always express on these podiums, is India is in a super hurry.
Huge.
We are in a super hurry. We are trying to bring molecules within 3 months, 6 months, which is not right. If you look at the Cimerelli and Biogen data, means I agree that biosimilars go through a curtailed clinical trial design because you need to show that equivalence. The design is equivalence. So equivalence design, your primary endpoints are 4 weeks, 8 weeks, and 12 weeks. Because that is a slope where you can check the equivalence. After that, you can't check the equivalence. So those are short. But if you look at international trials, your safety is assessed till 12 months, which we are curtailing here till 3 months. And then we are going in the market because we are not that worried by legality yet.
Avastin is still the cheapest in RP center AIMS, majority, more than 50% we are still having Avastin because it's cheap. And now next is the biosimilars. So what do you think if the Avastin is available with?
Sir, Avastin is still, that hang of safety still is there with Avastin. So I would say, with the competition coming in, you have really good pricing of biosimilars. So I think AIMS has shifted after really, really long time. On Resumab, and I know my colleague Vinod and everybody is using now even in ROP cases as well.
We have recently started in ROP cases.
Ashish, I have a few questions.
Yes, sir, please.
What is the percentage of refractory cases when you are using a biosimilar in an AMD patient with CNVM?
Sir, I do not have any statistics but I think this is similar that we used to have with Lucentis.
No. I think you need to come up with, I'm hearing you for a very long time, you need to come up with the hard data. What are the range? Because see, there are a lot of people, a lot of hands are raised for using biosimilar. It is cheaper, okay, it's monthly injection you are giving, it's also okay, but if it is not working properly, you are creating more visual handicapness than the highly
So I have a counter question on that. So I have a counter question on that. That's where I talk about that there is a nocebo perception we published. Negative perception should go away slowly.
That's why we require hard data for that. While doing this refractory status of the clinical cases, we need to have the percentage, not only for biosimilars, it is also for the branded molecules which are available with different molecules. We are having all those data with already worked out. So if you don't know that, then what I will tell the patient in cases where it is refractory to a biosimilar, I will shift this patient, irrespective of the cost, because here the question will come, how will I save the vision? It is not the pocket.
So I agree with you. So my question is, phase 3 has really, shown the equivalence. And so you should believe the data, what Lucentis has already given. We already have the data that in what cases ranibizumab work. So you should see with the same lens. There should not be a differentiation of the lens between Lucentis and biosimilar. That's what.
Not at all. Not at all. But you go by the agent, the particular brand is thing. And second is, will you use one injection is A brand, and the second injection that is required, second brand, B brand, will you use the biosimilars?
Yes, sir, we have done that study. So interchangeability we have tested, published as well.
And that is...
that does not matter. That doesn't matter. That doesn't matter.
That's good.
Yeah.
This
all biosimilar are FDA approved or the...
So DCGI approved in India.
DCGI approved.
Now I think we will go to the delegate. For all the speakers, whatever question questions you have, you can ask now.
Yes,
The speakers are also available. If they are not available, we will answer for that.
Yeah, we have some time, and
Please,
there is a
please
question
come
coming
to
up.
the microphone and then, let us
Ashish, before you leave, I just want to know, because if when we compare the studies, we have a population from West who are differently abled and otherwise also, health-wise, and as compared to Indian population. And we still follow the same studies to follow the protocols. Is there a dichotomy in this? Because insulin dependent versus adult onset. Just a small comment on this. I want to know, because this is something which troubles our mind. Yeah.
So I think, sir, in that way means the baseline parameters are fine, even whatever DCGI also advises. So baseline parameters are meshed. The only one trouble I see is DCGI is not mandating the one-time duration, which FDA and EMA really says that you have to have the 12-month complete study for safety.
That's the difference.
But otherwise, baseline, I think we are okay. Even DCGI maintains that.
Okay, thank you. The question coming from there.
Good morning, all.
Please be ready with your questions. We will accommodate as many.
I have actually two questions. One is like all these NTBs here. There is one thing I think we are not discussing. Many people had some cerebrovascular accidents after these injections.
True.
I think we have not discussed which one causes more or less, we really don't know. And number two, with that, once the 3 injection, 4 injection refractory happens, then you go for Ozurdex. Why not in the first shot only? And in that there is no cerebrovascular accident or any other complications. I personally feel it is less than this NTBCF.
See, the Ozurdex has issue because you do have other complications happening in the eye with pressure and with cataracts and other things happening. So one has to look at that also when we are giving an injection like that. Anything else you would like to add?
You see, the thing is, which condition are you talking about?
Diabetic.
Diabetic, yes. Because the audience are diverse and you need to be very specific. In diabetics, agreed. But in CNVMs, I don't think we should even consider Ozurdex as an option. It is only as in combination with the anti-VEGF. As you rightly pointed out, the cardiovascular complications are very common. One should have a good eye on the blood pressures as well as their cardiac status. This is very essential, and if there is someone who is undergone stent in recent days, it's pure it is contraindication for use of anti-VEGF very frequently. That life risk will be much more than the risk of fluoring vision.
Okay, can we have some comments?
Any other questions? Yeah, please come on to the microphone and please ask. Anyone, please be in the
Dr.
line.
Chandran, I look forward to your comments about the changing trends in management of these conditions, because you have the experience here.
Wait.
I just have a question. Any special precautions that need to be taken in a patient with an Ozurdex implant undergoing cataract surgery?
Undergoing cataract surgery. It's only risk is migration, which we fear. Otherwise, there is no special precaution is required. If there is any breach in the posterior capsule or the anterior hyaloid, both are equally important because it will not pass through anterior hyaloid and come to the anterior chamber. Yeah. But if posterior capsular breach is there is a risk of migration. Once it migrates, it may compromise the corneal endothelium and then the stability of the cornea.
Increased risk of infection?
Infection, yes. No, unless the cataract surgery, there are multiple identifying factors which can increase the infection rates, like prolonged surgery, breach in the anterior hyaloid phase, or multiple iris prolapse and handling. Those are the risks. In addition to the agents in the operating room, which we are not taking care, that can increase the risk. Otherwise, not so much.
Okay, I think we are lucky. Kenneth Fong is here, and we'll request Kenneth Fong to talk about. Okay, you can go ahead with your question. He'll wait for you.
Yeah, let him be ready with the presentation.
What I would like to ask is, nowadays many nephrologists in patients with nephropathy, they are writing anti-VEGF not to be used. So what is the cutoff level, or where do we decide that this patient I'm not going in with an anti-VEGF?
See, it depends on the stage of renal disease. Like if the nephrologist is telling you, please do not give, because that will cause medical legal problems. I have also found some patients who are coming back to me saying, I said, get a nephrologist's opinion whether it's safe for you or not. If the patient goes back, and then we are safe that why we have not given it to the patient. Okay? That's
it's all depends on the renal status and the level of creatinine and other diseases which the patient is having regarding renal. If you are not very happy in stopping the anti-VEGFs, go for a second opinion of nephrology. You need not stop with one opinion. You can have second opinion, and if there is a different opinion, you are in safe ground.
Ajit, this is come into literatures. There are some with nephrologists. You can take this road, but probably there is a reported things that terminal nephro diseases, one should not be giving this. I don't know what's
patient on dialysis.
No, that a limit should be there. If
okay,
it's
fine.
Very terminal then.
Okay, over to.
Yeah.
Thank you so much for making it here.
Thank you so much. I apologize for the delay. I was down in Hall 5 in an intense debate on neovascular AMD, so I just rushed up. Thank you so much for staying back. I've just got 8 minutes to share with you about an important topic that I think is not often covered in a lot of retina sessions, which is subthreshold laser. And basically, these are my financial disclosures. The only one of relevance is Quantel Medical, which I'm a consultant for them. Why do we still need laser for macular diseases? This is a perennial question I get in every single meeting I speak in, also with my subthreshold laser colleagues. Many countries, India especially, cannot afford continuous unending intravitreal injections. Even newer agents like faricimab with better durability, their patients with neovascular AMD are potentially needing injections for at least 5 to 7 years. Increasing cases of DME, CSR, and proliferative retinopathy, without a doubt, you can see as our countries in Asia become more affluent, you have all the non-communicable diseases increasing. Many cases, no matter what you give them, are unresponsive to the drugs, whether it's the latest anti-VEGF or the earlier ones. So what do we really mean by subthreshold? This is another question that often confuses people. Subthreshold laser means that when you perform the laser at the macula, you do not see any visible changes. You do not see a scar. So you cannot see it with autofluorescence, you cannot see it with OCTA, you cannot see it with OCTA, you cannot see it with FFA. Whether you reduce the power or duration of laserment, such as using endpoint management with other company software, whereby you see a burn at the beginning and the end of the treatment, this is not subthreshold laser. There was something called 2RT by Alex, which is no longer being used. They use very high power but nanosecond duration. So the pulsing technology that I'm referring to has been around for almost 20 years. This is called by many names: subminimal by Quantel, microsecond by ODOS, micropulse by Iridex, and smart pulse by Lumenis. How does it work? It works by changing the microenvironment of the retina, whereby you stimulate the RPE cells by a very low duty cycle power. You do not want to create a burn to kill the RPE cells, but you need enough energy to elicit a response. And this has been shown by many basic science studies, where there's upregulation of matrix metalloproteinases in eyes treated with subthreshold laser, which leads to normalization of the retinal vasculature and anatomy. What are the issues? We have many issues. They've been around for 20 years. Many doctors use different treatment parameters, and they've been publishing using 5%, 10%, 15% duty cycle, different spot size, different number of spots, and etc. If you are starting micropulse or subthreshold laser next week, there's a high risk that you're worried about overusing of power, because you have to go up to 800 milliwatts sometimes for some patients, and you might feel that that's too high a power for macular laser. So there's a high risk of undertreatment when you're starting out. DME cases often present late because we've tried everything else, like injections and steroids, before you convert to laser. We have no trials comparing subthreshold laser versus anti-VEGF, primarily because it's very hard to fund these trials. So what we did during COVID time was a group of us founded the Subspeciality Ophthalmic Laser Society to really understand and identify all these issues. These are the founding members, and I'm the treasurer of the society. Dr. Anand Rajendran from India, he's one of the executive committee members, and we're getting more and more members throughout the world joining the society, whereby we discuss these sort of issues every month, and we run webinars and courses and etc. throughout the world. So the aim was really to establish a consensus guidelines for subspecial laser. And what we did was, among us, we sent a round of questions to all the experts in the committee. This was led by J. Chablani, and whereby we had 1 round and 2 rounds of questions, independent of whatever laser machine device we use, they had to answer the questions. And for diabetic macular edema, the committee agreed whether you had center involving or non-center involving macular edema, with or without anti-VEGF therapy, you use a 5% duty cycle, 200 millisecond pulse duration, 150 to 200 micron spot size with no spacing between a laser spot using an integrated pattern system. And you do titration. Titration means you go outside the macula, you get a visible burn, you reduce the power by 50%, and then treat the thickened areas that we use to visualize on OCT. You do not need to treat any focal areas of microaneurysm, only the edematous areas with subspecial laser. You can treat the fovea. This is a very common question. 5% duty cycle is extremely low power, and it's very safe to do it. You do not need any specific imaging studies to evaluate laser spots, but you do need to follow up the patients at 6 to 8 weeks after the laser to look for resolution of the edema. You can give adjunctive therapies or anti-VEGF or steroid according to your discretion. What about CSR? CSR is a big issue because of worldwide shortage of Visudyne. It's very expensive to do PDT laser. Despite some trials showing some evidence that half-dose PDT works, subthreshold laser remains a very effective modality when you treat your acute and chronic CSR patients. And we use exactly the same protocol as you do for DME. So it's the same. You don't have to worry about that. Again, for CSR, you can treat over the fovea. You do need a fluorescein angiogram before laser to identify the hot spots. And then if you have a chronic CSR, treat the focal as well as diffuse leakage with the subthreshold laser. And you need to reevaluate at 6 to 8 weeks. So this has been published in 2022, and you're welcome to download this article. It's free to download from I. And again, I summarize in this table here: 5% duty cycle, 200 millisecond spice, duration, 150 spot size, and no spacing between the spots. And you titrate and reduce 50% of duty cycle. So this is the website. You're welcome to scan the QR code. If you have any questions, you wish to join the society, please by all means go ahead. And before that, I'd like to welcome you to Malaysia in July. We're hosting the World Congress of Ophthalmology, Pediatric Ophthalmology. Thank you very much.
Thank you so much. It was wonderful. Any questions or any comments from the audience? Babu, you want to say something? You're part of the group.
No, while Dr. Fang, while using this subthreshold, are you saying that half reduction from the standard power?
Yeah, so titration means, okay, so the confusion is because some machine manufacturers advocate fixed power. No matter what, use the same power and just laser away. But it may work in a Caucasian eye, which is lightly pigmented. But in Asia Pacific, we have varying pigmentations, degrees of pigmentations in RPE. So you might be over-treating Asian patient. So it's important to do the titrations, and you reduce it by 50% to avoid that.
Yeah, absolutely. This we used to practice for a very long time in CSR patients. When you are titrating, you will use the space nasal to the disc so that you first give a grade 2 burn. Once grade 2 burn is there, then you reduce it by 50%.
Correct, yes.
And then you should come on to the area where the leakage is there, and you deliver the laser whether you get the burn or not.
Yes, correct.
That is subthreshold, or we used to call photofomentation.
Yep.
This is the term we used to use before. Now it has come as subthreshold.
Yeah.
This is only the idea is to stimulate the retinal pigment epithelium for enhancing the healing process. Otherwise, what happens is the RP is supposed to be sick RP there, and it do not function effectively for the barrier function. So if you are using a subthreshold laser, it will stimulate and activate the RP so that healthy wound healing can happen in these cases.
How about your results? Because
Yeah, absolutely. I just like to reiterate what Ken said. We started doing the study as an LV Prasad about 5-6 years ago, and then the issue was about this fixed parameters. So like he mentioned, so if you check with some of our colleagues in Europe, they go by 400 milliwatts. What's there on the label. That does not work in Asiatic populations, pigmented populations, because you need to titrate because of the pigmentation. And that's why a lot of the cases then that we did not work out, and that's where this kind of this modality fell into kind of disrepute because people were using different modality.
Yeah.
So this is why our salts group has now we've fixed certain parameters, and earlier the publications which you'll see were all largely with 810 nanometers diode. So you'll find a lot of material enriched with diode, but with yellow, which is far more macula friendly, things are coming up now, and we feel this is, while it is effective right now for sick RP and CSCR, we're seeing great results now. I think this is going to be a game changer more for diabetic macular edema and putting some sort of a cap on the repetitive injections. So I think this is going to be a big game changer.
No, while using the subthreshold, certain times within the eye also, there is some areas where the pigmentation is more and some areas it is less. That's why you need to check two, 3 areas. And depending upon the pigmentation, you need to titrate. That's the basis for titration, requirement of titration. It is very much varied even with the same patient. That's why it is
also
required.
within the same patient with different points
Areas,
of time.
different areas.
Same patient, same eye, different points of time.
Time also, exactly.
2 years later, it might be
Agreed.
different.
that is why we are getting a different
There is
results.
another person who is waiting. Can you? Yeah.
Thanks for the opportunity. I just wanted to know, when you decide to repeat the lasers, plus how many patients you never needed injections again?
What percentage of patients?
Okay, so I only have 8 minutes to present the guidelines, but essentially to run through all the results would take another 30 minutes. But there has been a meta-analysis published. You may want to check on that. For both CSR and DME, we showed that there was about a significant reduction in vision and improvement in visual acuity with the laser. As to regards combination therapy with anti-VEGF, there's been very little published on it. Because there's been
what he's asking is, you are doing repeated injections and now you committed for subthreshold laser. In what percentage of patients you avoided repeat injections?
In my hands, it's about 20% you avoid repeat injections. So, if you treat it early, again, like at my earlier slide, if you had a patient that's at DME for 5 years with everything thrown at them, and then you're sending it to me for laser, I can guarantee you it won't work. So I think it is a question of chronic, acute, and what's the situation. But the majority of patients will have a response.
It's fair enough. See, even if we are having a patient with repeated injections, even 20% if you avoid repeated injections, it's a big gain.
It's a big gain.
So it's a treatment modality option you are having. That's what he's driving.
What I want to know, can we just start as the first line of therapy of this?
Or no?
Not for DME.
At this moment of time, no.
I think DME anti-VEGF is the first line. CSR,
Especially center involving DME. See, because here a lot of people are sitting. So we don't want to give a wrong message so that tomorrow they all start practicing again subthreshold laser for this. Center involving DME injections are the first line of management. Away from the center, depending upon the confidence that where the leaking is there, laser can be attempted as a first line. If it is a diffuse diabetic macular edema, injections are the first line treatment. Second line, if there is a repeated injections and a lot of burden is happening on the patient, option of subthreshold is there for you to explore. And you have a 20% chance of success in avoiding the injections, not 80%. Rest of the 80% may still require repeated injection. That's you need to understand.
The next question, yeah.
Yeah, Dr. Das.
Years back, as I remember, one of the eminent retina specialists of India, Dr. Vijayanand Patnaik, he was advocating this retina, this fomentation.
Yes, photofermentation. It is same.
Yes, same thing.
It is same.
There was also sometimes when we never used to see leaks, there was off the leak photocoagulation, like you do fomentation of that. Those were the history. One thing one has to realize that when you are deciding that waiting for the patient to become better metabolically, can we start? And that's a question to you. If the patient is metabolically not stable, and is it safe to start the micropulse?
Yeah,
because it doesn't have any systemic side effects.
I mean, like all diabetic patients, they need to be stable. But if they are not, if they're contraindicated for having an injection, high blood pressure,
because renal failure, renal thing. So are they safe for this kind of micropulse?
I think they are. There's no reason why you can't try laser.
I think that's a big thing. One has to understand that these patients.
What we need to highlight is even if you go for subthreshold laser, tell the patient that if you are not going to get controlled, then we cannot help you. This statement need to come. Otherwise, they will not take the treatment, systemic treatment serious.
That's primary. One has to take. Any more questions from the audience, please?
Dr. Patnaik was advocating this photofomentation for CSCR.
Yeah, we know that, sir. Yes, we have almost come to end of this second session of Retina Subspeciality Day, and the third session will going to come now. But
yes,
I would like to thank the chair, Dr. Prashant Agnihotri, and then rest of the chairpersons and moderator.
Thank you.
For a very lively session, and a lot of people got advantage out of this session. I thank all the delegates for active participation.
Overflowing halls, speak everything. I would come for a group photograph, please. All the speakers.
Yeah, and Ajay Dudani, I think you come and try to start the next session.